Thank you very much, Mr. Chairman. I'd just like to thank the organisers for giving me a chance to present this paper. Extrahepatic spread of colorectal cancer has traditionally been a contraindication to hepatectomy. That's been the case for the last couple of decades of the last century. In particular, lymph node metastases to the hepatic pedicle have been very much frowned upon in terms of continuing with liver resection, with only a handful of patients prior to 2000 actually lasting anything longer than a few months. With medical and surgical advances, however, there may be a chance that lymph node resection for these patients does have a benefit, whether that's for the whole group or a small group, would certainly be determined. We looked at our cohort of patients who've undergone liver resection at St James University Hospital in Leeds. We had 2,000 patients over a 21-year period, and of these, 76 patients had hepatic pedicle lymph node excision. So we're only talking about less than 5% of the patients here, but, well, for at least the purposes of this talk, it's an important 5%. We looked at age, type of resection, radiological imaging, location, and disease recurrence and survival, and obviously the histology of these lymph nodes as well. These are the results. To summarise, there are basically very few differences between the lymph node excision group and the total population. The males were slightly more predominant, and the resection status was very similar between the two groups, with about two-thirds of the groups being R0. And looking at this with univariate analysis, none of these differences, if any, were significant. So looking at the Kaplan-Meier curves for disease-free survival, you can certainly see a very significant difference between our total population and the lymph node excision group, with the lymph node excision group having a majority of patients regaining disease within the first 24 months. But there is a group of just above 20% there who go on to long-term disease-free survival. Similarly, with overall survival, a big difference in terms of outcomes. The overall survival rates are certainly much less after about the 3-year mark. So looking at the histology, we found that exactly 50% of these lymph nodes that we excised were positive for tumour, and between these two groups, again, no significant differences in the number of patients, age, gender, number of tumours, type of resection, R status. So looking at these groups, it is now clear that the ones who don't have tumour in the lymph nodes, surprise, surprise, do pretty much exactly the same as our total population, with a significant a decrease in disease-free survival for those with positive lymph nodes. And again, with overall survival, there is also a big difference, again, with the histology negative group having a similar survival to our total population. So we looked into a couple of differences here. In terms of the radiological imaging, would this help us decide if lymph nodes are positive or negative? Well, the answer is not really. You can see on the left-hand side, in the histology negative group, there were a couple of patients that CT and MRI said nodes were very, very suspicious. The majority were not suspicious on these scans. But on the right-hand side, you can see the majority of patients also had negative CT and MRI scans. PET scanning now starting to come in for our patients. The numbers aren't really significant enough to say for sure, but certainly the PET scans seem to be quite accurate in determining which is tumour and which is not. Other groups have looked at the location of lymph nodes in the hepatic pedicle. At one time there was thought to be a theory that all of the lymph drainage came through the hepatic pedicle first, then to the retroperitoneal nodes, and then to the more proximal common hepatic and celiac chains. It seems more obvious now that the metastases can go almost anywhere, and skip lesions are common. And in fact, lymph nodes that come from either location, there's absolutely no difference in survival. To conclude, Mr. Chairman, patients with hepatic pedicle lymph node metastases do have very poor outcome. However, hepatectomy and lymph node resection is justified as imaging and operative findings are really poor guides in determining who actually has positive lymph node disease. Thank you very much.